Thank you.
Thank you.
Dr. Manuel Cornely now has come all the way from Germany to deliver his insights into 30 years of treatment of Lipohyperplasia Dolorosa.
Thank you very much. I thought we were joking. As you heard, I'm coming from Germany, so I'm native speaking German. So I apologize, my worse English, which is school English I learned, I don't know, 50 years ago. So all the mistakes, ask me if I'm telling stories which are not English or American. Thomas asked me to give a few minutes on my experiences on what you call lipedema, and what is well known as lipedema since the 40s. And I would like to tell a little bit my story and what I'm doing and what we did up to now, and maybe these are some few ideas for you. So we called it 25 years of surgical treatment of, you see the other name, Lipohyperplasia Dolorosa. I will explain this. And I shorten it with an acronym Lido, so it's easier to spell. And at the end, I was asked to have some recommendations for the future. I will try this as well, and then we have something to discuss. So I have no disclosures, even I'm the chef of this company, which is research, which is only doing science in lymphology. My first contact with lymphology was in 1992 when I became educated to become a dermatologist. So I'm a dermatologist, I'm not a plastic surgeon, I'm not a cosmetic surgeon at all. And this is the way I look on this disease from the lymphological way. So I was trained in lymphology and dermatology with all these things around there. By Professor Marsh, he was my teacher, he's my teacher, and nowadays he's my friend. And we had some questions when I read the papers from Alan Hines, and I saw the patients, and so we started to do a science way, which I like to call it in applied lymphology. I'm not a baseline scientific. What we do it is in applied lymphology. What is all the day done with the patients, and what can we do to have better treatments and better outcomes from them. So we had surely questions to the opposed tissue. We had to, first I'm wrong. No, wrong direction. Okay, so as everybody in this room does, we want to know what's opposed tissue. We want to discriminate lipohypertrophy from lipoplasia and obesitas, and we know the coincidence, and I call it coincidence and not comorbidity with the adipose people. Ladies, in Germany we have around about more than 50% of women more aged than 40 which are obese. So the coincidence of lipedema patients and obese patients is normal. What is necessary to see the difference? If we treat them as an obese, for example with bariatric surgery, at the end we will not have good effects in the lipedema. In the other way around, it doesn't work. As you know, you're becoming obese, you can train it or you do bariatrics, okay, but you will know effects in lipedema, not really effects. So we're currently focused on the question, what is these adipocytes? Is a hyperplasia? And we think it is. We have new paper done by Erich Brenner, which is written down there. It's in press at the moment. So years ago, I said that's something with the increase of amount of cells and nothing with it, and it's a normal volume. That's quite a point to discuss. This was the histology from this paper. What we know nowadays is that there are lipohyperplasia cells, a huge amount of cells. but these cells are able to have as well a lipohypertrophy and returning. So sometimes they work like normal adipocytes, but even when you reduce the size of lipohypertrophic cells in your depositors, you can reduce this maximum, but you will not take the cells away. And this maximum is somewhere finished in obese patients. It's quite earlier finished in lipedema patients. At the end, they stay with these cells, and it's one of the things we are looking at the moment, as well with the Life Foundation. We are discussing these things. So the second, it's the question of the edema. What's with the edema? In the early 1992, this was my question as well. And I said, there is no edema. Even Alan Heinz didn't describe an edema. They just said there is an edema of the legs, which is orthostatic. They did never discuss the arms. You will not find a word on the arms in their papers. But as you know, quite more in our experiences, around about 80% of the ladies have the same problem in the arms. So there cannot be an orthostatic edema. It's no discussion on this. So Karen knows my words in these. There is an edema between the cells. It's like a sponge filled with water. This was the picture I used to train in 1992. And what we have to know is how we can take the sponge away. What we do with manual drainage is to bring the water out of the sponge, and the sponge stays what it is. But we wanted to remove the sponge. This was the idea. So we're still working on this theme, and we have figured out that it's indeed a question of lymphatic edema. Now careful. Water which is in lymph vessels is called lymph. Outside of the vessels, it's not called lymph. It's just water. But what we know is that these patients have a problem with the transportation rate of their lymph vessels. This was shown by Bender in, 2007, I think, something around like this, with very good methods of lymph scintigraphy. So this is the baseline of our idea. We think and we know that it's a high volume lymph transport insufficiency. When I started with lipedema, and all the books was written, the vessels are damaged. And this is wrong. The vessels are not damaged, and they have not changed because it's not a lymphedema. In lymphedema, it's another question. But in lipedema, I do not know any papers which will tell us, okay, there's a damage in the vessels. So I think these vessels are normal, but the transportation capacity is over the level. So it's called high volume lymphatic transportation insufficiency. So one way could be to bring down the water liquid in the fatty tissue to regulate the transportation capacity, and that's what we do. And the last, as well, in 2005, I said, taking all these things and ideas together, that lipedema is a wrong name. Yeah, it's a misnomer. And so I published, due to the size of the cells, lipohyperplasia, and necessarily painful, they have pain. These patients without pain do not have a lipedema. That's our discourse on this. So, Karen, I read your paper yesterday night to the US, and there were 89% with pain and 11 without pain. Did I understand this correctly? So in my world, I would say these 11% have no lipedema. So without a pain, it's well treated or something else. That's our opinion. Quite necessary is to remember that it's a clinical diagnosis. There is no blood test, no histology or something like this. We need a good clinical diagnosis. And so I just want to show you how I do it since more than 25 years. First inspection of the distance, just to see what's with the proportion. You can see she is not obese. Then close up to the feet. I want to see if there's anything lymphological. Stammer signs positive, pressings in the back of the feet. Can you see, for example, very easy, the vessels in there? If you can see the vessels there, there's no edema. That's very easy. Then quite interesting is this sign down here, these Bisgard Kulisse. I don't know the English expression. It's written by a Danish guy, Bisgard. It's this area down here. Yes, you've got this with painful pressure in there with thrombosis, but that's not a good sign. But in lipedema and in lymphedema as well, you will find this closed. There is no curve like this in this area. Well, it is closed. It's filled up with fat. So then I really need to point out what we need is not a pinching test. The pinching was first described by Friedrich Nürnberger. He's a German dermatologist in the 70s, and he described it to have a word on what we call cellulite. It's not cellulitis, it's cellulite. And he had a very, very good, well-done paper to a family with old lady, mother and child, and he did deep insertions, deep histologies down to the muscles, and he showed the fat. All discussion on structure of fat goes on this work. And in this paper, Guy, I will send you this if you do not know it. I know it's in German, I can translate it. In this paper, it's first time written that you need a pinching test because a cellulite never has pain. And if you read this paper exactly, you will see there is no sclerosis, there's no edema, there's no infection, there's nothing like this. It's just the change of the age of the fat from the younger to the older aging, and he as well combine it with hormonal investigation. So this is quite a very good paper, just to see what we know since the 50s, 70s, to this common thing, cellulite. In lipedema patients, in Lido patients, we never need a pinching. We just need a palpation. What a dermatology know is just bring the hand on, smooth, and do like this. Never grab in there. This is painful, what I'm doing there. That's enough. And I figured out that I always used to do the examination these areas, the lower iliac, the upper arms, for example, and never try in here in the inner thighs because they're always painful. Nobody loves to be touched in there. But if it's painful on the other thighs, that's not normal. And I do the same in the arms, necessarily. And then I do it bimanual with two hands, the arm and the abdomen. Here's the discussion with Karen, what's up with abdomen and Lido, and we have to discuss. But for me, this is a typical sign. The patient says, and that is necessary to have the diagnosis. Just palpation, no pinching, never pinching. I never pinch. You see it in my hands here. It's just palpation. And then she says, my arm is painful, and my abdomen is not. And so you can show in this person that she first time knows, okay, what's that? Different areas, different pain, different fat, and that's a clinical device I'm working with. So it's intra-individual necessary. For this very strong diagnosis, it has to be painful. If it's not pain, it's something else, but it's not a lipedema. So I was the first who did this surgery job in Germany, but the same year it was Hakan Brazon who did his first suctions in secondary arm lymphedema, something very different. And I did it first in 1997, and Rapprich and Schmeller followed a few years later, and surely we had studies on the efficiency And I did my first study in 2005 after I had surgery done in 140 patients. And quite a lot of them we had, before we did the surgery, we had a lymphscintigraphy. And 7 years later, the same colleague, again, scintigraphy, because we wanted to show that we have no damage in the lymphatic vessels. This was what all the opponents said. If you do surgery, they will have a lymphedema afterwards. Yes, you can produce a lymphedema if you're not able to do it the right way with the surgery. So we did as well our job in the cadaver. We went to Innsbruck, to the anatomy, to our friend Erich Brenner. He is the guy in the middle, and this is me years ago. And we did the same maneuvers of the procedure of the surgery in this cadaver. And then we wanted to say, then the anatome, here's the anatome. I said, please prepare all these areas we did the suction in and show us what is up with the lymph vessels. And you can see the lymph vessels were never damaged. So it needs to have a maneuver which has to be very certain for these patients. We called it lymphological liposculpture to discriminate it from plastic surgery treatments in cosmetic suctions. It's a lymphological disease. We have to call it another way. That's the way we call it. And it's always from two parts, two steps. The one is we resect the fatty tissue between the skin and the muscle fascia completely. You remember in plastic surgery, you will never do it this way. You have the idea the fat is a three-layer thing, and you take away the middle layer, and you leave the upper and the surfacing. The deep and the upper you leave, you take away the middle, and you have a nice shape afterwards. You cannot do it this way in lipedema patients. If you do it, it will stay painful. This might be these results from those who had surgeries, and it's still no results in pain. They are incompleted surgeries. I would say they're incompleted surgeries. I know this because I did it wrong myself. In the early start, in the beginning, nobody was there to tell me how to do it. So I was very careful. And then a lady came back and said, wonderful idea, everything's good, but I can show you exactly there and there and there, it's painful. And that's where still fat was inside, and we took it away, then the fat was, the pain was going away. So it's applied lymphology. It's not, I cannot give you a scientific paper what is done with the fat and the pain. We are working on this, but that's what we do since 25 years. And always we do it in TLA, tumescence local anesthesia, which is a method which was given first by Jeffrey Klein in the 70s. That's nothing we have to do is new. We did another solution, okay, but it's the method is always TL, tumescence anesthesia. And why? Because I will show you afterwards. And the second step is always when we take away the fat, we do an amputation, then we did nothing